Hello and welcome to our EKG workshop. This is session 2. If we look at EKG from a patient, we see 12 leads usually in a strip. You have 6 leads. The bipolar leads are 3, the unipolar leads are 3, and then you have another 6. These are the precordial leads. So lead 1, lead 2, and lead 3 are bipolar. AVR, AVL, and AVF are unipolar, and then you have from V1 to V6, these are the precordial leads. So bipolar leads, lead 1 is the right arm and left arm. Lead 1 is at 0 degree here, we can see. Lead 2 is at 60 degrees, but it is the right arm and the left leg. And then lead 3 is at 120 degrees, and it is the left arm and left leg. So if we connect these 3 lines, lead 1, lead 2, and lead 3, we get the Eindhoven triangle. If we look at the unipolar leads, AVR is at minus 150 here. AVL is at minus 30, and AVF is at 90 degrees here. The precordial leads you have from V1 to V6. Now let's look at determining the heart axis. So we can look at 0 degree to 90 degree. These are the places where we have lead 1 and AVF. So if the sum of QRS complex is positive in lead 1 and in AVF, then we can say the axis of the heart falls between 0 to 90 degrees, which is for the most part something that can cover most normal heart axes. If it is negative in AVF and positive in lead 1, then we are talking about this quarter, and this is left axis deviation. If it is positive in AVF and then it is negative in lead 1, then we fall into this quarter and we have right axis deviation. If both of them are negative, both lead 1 and AVF, then we have extreme axis deviation. Now let's look at steps how to read EKG. So first we want to determine if there are some technical errors. Usually we think about technical errors if everything is really small or everything is really big. So you can see the calibration right when you start reading the EKG. You have something about calibration, and you can check the leads and see if everything is okay. If there is no problem like that, we don't have any technical problem, then we determine the rate. So we look at the RR distances. If they are regular and the length of the RR distances are pretty much the same, then we can just count and see how many big boxes we have between the RR waves. And if this is between 3 to 5, then we have normal heart rate. What does that mean? So 300 divided by 3, that means you have a heart rate of 100, and then 300 divided by 5, that means you have a heart rate of 60. So between 3 to 5 means you have a heart rate between 100 and 60. So you don't have tachycardia, it's not more than 100, and you don't have bradycardia because it is not less than 60. So very easy. You can just look at the EKG, and by checking the RR distances, you can say if you have brady or tachycardia or not. Then you look at the rhythm. So you want to see a P wave before every QRS complex. If you have that, this is sinus rhythm. Then you look at the P wave to see if there is right atrial hypertrophy or left atrial hypertrophy. So right atrial hypertrophy is P pulmonale, so we have more than half of a big box as the height of the P wave, which is more than 2.5 millimeters. Or you can have P mitrale, a notched P wave that shows left atrial hypertrophy. After the P wave, we look at the PR interval. If the PR interval is prolonged, then we have first degree heart block. That means it is more than one big box. So one big box has 5 little boxes. Each little box is 0.04 second. 5 times that is 0.20. So if the PR interval is more than 0.20, we have first degree heart block. So if it is less than a big box, you don't have first degree heart block. You don't have prolongation of the PR interval. Then we check the AV blocks, other types of AV blocks that we will explain later. And then after that, we can check the QRS complex and see the length and height of it. So if it is wide, then it can show bundle branch block, or we can see hypertrophy of the right or left ventricle. Then we determine the heart axis, as we explained that a little while ago. Then we look at the QT interval. So if the QT interval, if it is prolonged, then we can think about certain dangerous tachycardia like torsades that can develop. So the best way to determine the QT interval is the corrected QT interval. The corrected QT interval is QT divided by the square root of RR distance. If this is less than 440 milliseconds, then it is normal. If it is more than 500, it is most likely prolonged and significantly prolonged. In women, it is a little bit longer than men. Now we look at the Q wave, the ST segment, and the T wave. So these are ischemic changes that we can see here. In fact, many physicians, after checking the heart rate and rhythm quickly, they would look at Q waves to see if there is a pathologic Q wave, and then they see the ST elevation or ST depression. ST elevation is a sign of myocardial infarction, and ST depression is a sign of myocardial ischemia for the most part. Then the T wave changes. If there is some negative T wave, that could be a sign of myocardial ischemia or infarction. So to miss changes in the Q wave, ST segment, and T wave, that could be a very big mistake, because you can miss myocardial infarction or ischemia. Then we look at the U wave, that in some normal subjects we can see it, otherwise it is a sign of hypokalemia. So if you follow these steps, you can very quickly find out a lot of information about the EKG strip that you are looking at. Thank you for your attention, and we'll see you next time.